The upper layer is mucosa maybe, and the downwards are the submucosa and muscularis.
Mm-hmm. Very good. All right. So what do you think is what layer is involved in this?
It definitely has vitamin B12 deficiency, as the picture
Mm-hmm.
indicates, MCV, which is higher. And
Mm-hmm.
I think that the restriction of gastric layer is in the region of A, the uppermost layer.
Yeah, this is pernicious anemia. Yeah.
Okay. Again, um, very easy. This is the upper glandular layer. This is the deeper aspect of the glands. This is muscularis mucosa, submucosa. Again, when they said that MCV is greater than 100, that means you're talking about macrocytic anemia, and usually that occurs in vitamin B12 and folic acid deficiency. Over here, they're talking about pernicious anemia. And they're found in the upper glandular cells. Again, very easy. If you have deficiency of vitamin B12, you can get paresthesias and ataxia. There is also other vitamin deficiency that causes paresthesia and ataxia. What's that?
Vitamin E.
E.
Very good. Vitamin E. But there won't be any hypersegmentation and the MCV count will be normal. All right. Okay. Next question. Endoscopy shows nodular gastric folds, and biopsy shows proliferation of small clonal mucose-associated B cells expressing the CD20 antigen. Which of the following microbe-induced mechanism is the most likely underlying cause of the finding seen in the patient? So we have a 60-year-old woman. She comes to the office because of worsening dyspepsia and unintentional weight loss. There is no cervical or inguinal lymphadenopathy. Abdominal examination shows mild epigastric tenderness. CBC and serum chemistry results are normal. CT scan of the abdomen reveals gastric mucosal thickening, but no evidence of abdominal lymphadenopathy or hepatosplenomegaly. What do you think is happening?
It's actually the Mart lymphoma.
Malt lymphoma, yeah. Chronic immune stimulation, yeah.
Chronic gastritis, the type of autoimmune gastritis. So that's
Again, so we talked about that how Mott lymphoma is associated with, it's a form of non-Hodgkin's lymphoma, and it arises from post-germinal centers. It can include CD19, CD20 as well. Again, mild lymphoma trigger is usually H. pylori infection. So if a patient is having recurrent episodes of gastritis or chronic gastritis, they're more likely to develop mild lymphoma over time. Again, most cases of gastric lymphoma are they're very tightly linked to H. pylori, and that is why antimicrobial treatment is usually started at a early stage. All right, where do you see this E6 protein mediated P53 inhibition? Where do you see this?
HPV.
Very good. HPV. All right. Okay. Next question. What is wrong in the labs?
It's the megaloblastic anemia.
yes.
And the basically the folate level is high.
Hmm.
Folate level is normal.
Folate is normal.
Normal. B12 is deficient. Vitamin B12 deficiency anemia.
Mm.
Mhm. Intrinsic factor is negative.
Mhm.
Mhm.
I think it's pernicious anemia.
So the atrophy of pancreas with multiple calcifications, it's chronic pancreatitis because of atrophy and calcifications.
Yeah.
Mhm.
And the fat malabsorption should be there. Fat soluble vitamins will not be absorbed.
Yeah.
And the
And this is the enzyme mediated cleavage of the cobalamin from R protein. Yeah.
pancreatic protease enzyme, which basically released from the pancreas, that causes the breakage between the vitamin B12 and the R protein, so that the vitamin B12 can bind with the intrinsic factor for reabsorption. So that enzyme will be deficient here. So that is the C enzyme mediated cleavage.
All right. Okay. So it's C. Again, very easy. Those who have learned pathology know about that. Pancreas, vitamin B, this R protein, it comes from the salivary glands. And so it kind of goes down, and then there's pancreatic protease. It kind of separates that R with B12, and that is why B12 then binds with intrinsic factor and gets absorbed. So there's no pancreatic protease, and it cannot separate that, and then vitamin B12 will not be absorbed. Then that means either two things: either intrinsic factor is deficient, or there's deficiency of pancreatic protease. But they said that the intrinsic factor antibody is negative, which means intrinsic factor is okay. So in this case, they're talking about a case of chronic pancreatitis with calcifications. Whenever they say calcifications, it's most likely chronic in nature. And so again, it was chronic pancreatitis. You do not have the enzyme. It cannot get cleaved from off there, and it cannot get absorbed. And as a result, we're having vitamin B12 deficiency. Again, very easy. All right, next question. Okay. In another experiment, a substance is added to the folate deficient media. The substance prevents apoptosis and permits proliferation of some of the pro-erythroblasts. Which of the following is most likely substance added to the growth medium? All right, so what's happening that there's an animal experiment that's been conducted, and there are murine pro-erythroblasts are cultured in two different growth media. The first medium is folate deficient, whereas the second, it's kind of controlled with additional folic acid. Both media contain high concentrations of EPO over 48 hours. The cells are proliferating and they differentiate into reticulocytes, whereas the folate deficient media cell proliferation is minimal and a lot of cells go apoptosis. So what's happening?
So basically, when thymidine will be added, so it will rather bypass that reaction, which the deficiency of folic acid was not able to do. So then the cells will be easily able to undergo proliferation.
Mhm. All right. Okay. So the answer is
E, that
Thymidine. E.
thymidine. Again, so we know that folate, it's kind of converted to dihydrofolate, and then dihydrofolate is converted to tetrahydrofolate, and to convert that we need thymidylate synthase. Again, it's a biochemistry oriented question. Dihydrofolate reductase is a rate limiting step, and it's kind of get triggered if there's folate deficiency, or if you give methotrexate, which is anti-folate. So for tetrahydrofolate, you also need this thing called thymidine, and it's like a cofactor that's present with that. So again, very easy question. It's a biochemistry question. We will cover this in the biochemistry high yield section as well. So just go through it. All right, next question. The patient does not use tobacco or illicit drugs, but does consume alcohol regularly. An upright abdominal X-ray reveals calcifications in the epigastric area. What do you mean by calcifications in the epigastric area?
It's a chronic.
that kind of
Chronic condition.
Chronic
Yeah.
pancreatitis. Chronic
Mhm.
pancreatitis.
Yeah. It
And-
is digestive enzyme deficiency, definitely in chronic pancreatitis.
Mm-hmm.
Yeah.
All right. Okay. So the answer is
D.
enzyme deficiency. Again, so we talked about that whenever there are calcifications, they're most likely referring to chronic alcoholic pancreatitis, plus the patient was having diarrhea as well, weight loss, abdominal pain, all are classic symptoms of chronic pancreatitis. Again, it can the most common cause of chronic pancreatitis is alcohol related in adults, and in younger children it's most likely related to cystic fibrosis. There is acute pancreatitis. The most common cause are gallstones. All right. So go through this again. If you have exocrine insufficiency, you can get malabsorption, which is consequent with diarrhea, steatorrhea, and that is why the patient is having diarrhea. And weight loss, again, that suggests that it is pancreatitis in itself. We have chronic diarrhea and there's weight loss. That means there's certain malabsorption thing going on, which means that probably there is a digestive enzyme deficiency. All right. Okay. Next question. Barium swallow shows a dilated esophagus, and manometry confirms absent peristalsis in the smooth portion. Again, very easy. Immigrant.
Eclasia.
Eclasia.
it's eclasia caused by the T-cruzi, trypsinoma cruzi.
There is immigration history.
Yes.
Trypanosoma cruzi.
Trypsinoma.
Immigration is the tryposoma.
Mm-hmm. Very good. So,
Trypanosoma cruzi. It's the Chagas disease.
very
F.
good.
Yeah.
So whenever they're talking about the dilated esophagus, it's most likely
Yeah.
in Chagas disease. We talked about that in Chagas, you get mega esophagus. You also get, cardiac
Megacolon.
manifestations, megacolon. You also can get dilated cardiomyopathy with biventricular failure. Again, that's Chagas. That's caused by protozoa Trypanosoma cruzi. Again, so whenever they're talking about immigration history, two to three things are very common. First is trypanosoma is very common. Tuberculosis is also very common in immigrant patients. And what's the third?
Schistosoma.
Hmm. There are a lot of other pathogens as well, but sickle cell. There are again a lot of diseases that are usually found in immigrants, and they're not found in America in itself. So this can also kind of give us away that what the answer is. All right. Okay. Then we come to the next question. The diagnosis of acute pancreatitis is made and a specific etiology is established. Which of the following additional laboratory findings is most specific for the underlying cause of the patient's pancreatitis? All right. So we have a 45-year-old man. He comes to the ED due to sudden onset vomiting and severe abdominal pain that radiates to the back. All right. So they gave us a classic picture of acute pancreatitis. The AKP is also really high. Serum lipase is increased. What else do you see? I think this is this.
It will be the macrocytic anemia because when it is
Macrocyt.
pancreatitis, so the proteases won't be released. So vitamin B12 deficiency
I
would occur.
think it will be A. Yeah.
Yes.
Why
Yeah.
cannot it be?
Um,
It
serum
does not have
calcium is normal here.
serum.
Serum calcium is it?
Hmm.
It's normal level. It's normal serum calcium level.
Mm.
Actually, this is acute pancreatitis. So, because of the macrocytic anemia and history of
Alcohol.
alcoholism, that's why.
Yeah. And calcium level
Then,
is normal in acute pancreatitis.
Hmm.
Yeah. Mm.
Then when
like
does the
because
calcium
of the
deficiency?
alcoholic history, she got acute pancreatitis. So, in the and mostly alcoholics have macrocytic anemia.
Yeah.
Mm-hmm.
Yes. Mm-hmm.
Folic
Yeah.
acid deficiency. Yeah.
Yeah. Mm-hmm.
Again, so MCV will be greater because the patient is alcoholic, and again, alcohol it causes folic acid deficiency, which causes increase in the MCV. Serum calcium is decreased because you remember that in pancreatitis it also causes saponification, and as a result,
Mm.
we have decreased calcium levels. So, if it is asked what is the most lethal complication of acute pancreatitis, that's this. So, if you have a calcium level which is lesser than the said limit, then there are a lot of things that can happen within your body. All right, so it's like a complication of severe acute pancreatitis, like I said, right? So what happens is that it results in hypocalcemia. It is called as saponification, sea forming soaps, and again, it's one of the most severe complications that can even lead to death. So if they ask you what's a severe complication, that's serum calcium level of 8. All right. Okay. Next question. 23-year-old comes with acute pancreatitis. It resolves rapidly. He's had several episodes before. A gallbladder ultrasound is normal. The patient has no other medical condition. He does not consume alcohol. Which of the following tests should be done in the patient?
Serum triglycerides.
Yes, serum triglycerides.
Yes,
Again,
it's
very
right.
easy because I don't know if you have kind of remember the mnemonic get smashed. So that's the cause of
Yes.
pancreatitis. Also
Mm-hmm.
ethanol, triglycerides, and then scorpion sting, mumps can cause pancreatitis. Then there are certain toxins that can cause. Then what else? What else can cause pancreatitis? Some drugs, some strictures.
And
So
ERCP can cause by the mechanical trauma and also the trauma
Gastro.
like seatbelt injury during the road accident. It can
Very
cause
good.
pancreatitis. Yeah.
What do you
scorpions.
give when triglycerides are greater than 1,000? What medication do you give?
Insulins.
Jim
Fibrates. Fibrates.
Bright.
In
Where is
You know,
it?
so there's this medication that you give, phenofibrate. You give that when tags are greater than 1,000. If the tags are lesser than 1,000 and they're in 500 range, then you give statins along with, certain dietary modifications. But phenofibrates are very characteristic of, greater than 1,000 tags. All right. Um, okay. All right, then we come to the next question. EGD is performed and reveals esophageal hyperemia and linear ulcerations. Where do you see linear ulcerations?
CMV.
This is
CMV.
Cytomegalovirus. Yeah.
Cytomegalovirus.
Again, you see pneumocystis, Darvish in immunocompromised patients, right? Plus, the patient is also IV drug user, and linear ulcerations, it kind of goes with the CMV or cytomegalovirus. Again, very easy. They gave us in the Wignet that pneumocystis, IV drug usage, linear ulcerations, all are that. Okay. Then we come to the next question. Okay, the patient subsequently undergoes an uncomplicated subtotal pancreatectomy and returns for post-op nutritional assessment, which the following test is most likely to be normal in the patient after surgery. So, there was this chronic pancreatitis patient who comes to the ED, and there's, diffuse atrophy, temporal wasting, and a mildly enlarged liver without ascites. Serum lipase and the rest of the things are normal, but AST is mildly elevated. Abdominal imaging shows a malignant mass in the pancreas. And a surgery was done post-op, which level will be normal?
I think C.
Xylose
Between
absorption will
Understanding
be
B
normal.
xylose absorption. Yeah.
Xylose absorption will be normal because it is not releasing from the pancreas. Other, the lipase, trypsin, trypsinogen, and the fat content, they all will be decreased.
Yeah.
Because in these xylose absorption will be decreased in case of villus atrophy or in the celiac disease. It's not the pancreas problem.
What is the answer?
C.
C. Yeah. So we know that the exocrine pancreas, they have a significant CK3 reserve of the glandular tissue. And what's important is these lines. So we know that monosaccharides can be absorbed directly, but D-xylose is a monosaccharide whose absorption is not affected by the exocrine pancreatic insufficiency, and that can be kind of used to differentiate between pancreatic versus mucosal causes of malabsorption. Again, this is a very high-yield question. It can come in your exam as well. So you need to learn the concept behind it. Again, very easy concept. All right, next question. What's this?
iron
Iron
deposition.
accumulation. Yeah.
Very good. So we have a patient who dies with congestive heart failure. There's dilated heart, brownish pigment of the pericardium, profuse GI bleed at age 43. Patient's disorder is hereditary. Very easy. Delayed onset of her disease.
It's because of the premenopausal menstrual bleeding, because as long as she was menstruating, she was losing that excess iron. But now
Yeah.
she's 63, so she couldn't.
So we discussed this answer in the rapid fire as well. The women have delayed presentation of hemochromatosis because of menstrual bleeding, and that is why the disease develops at a later course. Again, very easy. All right, what's wrong over here?
Sarcopenia.
Elevated eosinophil, maybe parasitic kind of infection.
Schistosomiasis. Yeah.
Schistosomiasis.
Yeah.
So
Because
then,
eosinophils are also raised. And
Yes, esophageal varices are because of portal hypertension, and the portal hypertension cause is the schistosomiasis causing the portal hypertension. And the patient also immigrated from sub-Saharan Africa is also the clue. The abdominal palpation reveals enlarged liver. Hepatosplenomegaly is also there. So it's
Yeah.
because of portal hypertension, the schistosomiasis, Japanese Japonicum.
Yes,
Japonicum can cause the portal hypertension.
Yes, yeah.
Again, schistosomiasis can also cause, urinary schistosomiasis, which can cause bladder cancer as well as squamous cell carcinoma of the bladder can happen. There's intestinal and hepatic as well. Again, you see the immigration history, eosinophil count is very high. Again, that means that it's an, any helminth infection as well. So it cannot be this, it cannot be this, it cannot be this. And then why cannot it be a hookworm infection? Because it does not invade the hookworm does not invade the liver. You see the liver involvement over here. So again, the liver is hepatic schistosomiasis, intestinal, urinary. It includes three things. The species type is not important for you to learn, but just remember what schistosomiasis presents as, and that's enough for you.
Urinary schistosomiasis is also like high presentation, like the young boy who had swimming in a lake and then presents with the painless urine, like painless like bloody urine, something like that, right?
I'm sorry, I couldn't hear you. What did you say?
Like this is also very high. This is also very high yield for the urinary schistosomiasis. Like anyone who went to the sub African, like for the vacation and had
Yeah,
swimming in a lake.
yeah. You're right. All right, next question. What's wrong over here?
The pseudocyst formation in the head of the pancreas.
So
It's a large hypodense area. It is like a pseudocyst
yeah.
in the head of the pancreas. It's a
All
complication
right.
of acute pancreatitis.
Very good. So we know pseudocyst is a complication of that. So what do we see?
Yes. Fibrous and granulation tissue.
It is not lined
We
by
see granulation
epithelium.
tissue.
It is lined by granulation tissue. Yes, D.
D is the answer. Yeah.
So it's D.
Yes.
Yeah. So again, we see that this is a pseudocyst. It's in the head of the pancreas. Again, it's a very acute complication of acute pancreatitis. We know pseudo means fake, which means it's not a good, it's not the real tissue that's surrounding it. So there is no epithelium in that, but it has fibrous and granulation tissue. Again, you take the patient to surgery to drain the pseudocyst. Otherwise, it can rupture, and the infection can spread throughout the body as well. And yeah, see, they're not lined by epithelium. So, okay, next question. Okay, skin examination is shown. Let us see. What's this?
Folliculitis.
Folliculitis. Vitamin C deficiency. Yeah.
Again, very easy. If you kind of see subperiosteal hematomas and you see poor dentition, swollen gums, all of them, picky eater, and the rash has been progressed. Again, all of them means that there's ascorbic acid deficiency. So you need to memorize these water-soluble vitamin deficiencies. A very high yield for your USMLE step 1. Vitamin B1, it causes beriberi. We discussed that Wernicke-Korsakoff, peripheral neuropathy, and heart failure. Riboflavin is B2. It causes teleosis, stomatitis, and glossitis. B3, pellagra. There are 4 Ds. 3 Ds are mentioned over here, but there are 4 Ds. Dermatitis, dementia, diarrhea, and death. So it can also cause death as well. Then there's vitamin B5. They don't ask you about this. They ask you about vitamin B6. Again, it causes, teleosis and stomatitis along with peripheral neuropathy. That's very high yield. Vitamin B7, they don't really ask. Vitamin B9, they do ask. Megaloblastic anemia and neural defects. Cobalamin is vitamin B12. Again, very high yield. Megaloblastic and neurological. Ascorbic, impairs collagen synthesis. We talked about this, and that is why you have perifollicular hemorrhages and gingivitis and muscle pain along with that. Again, very high yield for you to go through the vitamins. All right. Then we have the next question. The child was born at Kermit home. He is at the 28th percentile for length and 3rd percentile for weight. The child appears thin and has a non-tender, non-distended abdomen, which is the following is most likely present in the patient. So we have a 15-month-old boy who was brought to the ED because of poor weight gain. The parents have noticed frequent large foul-smelling stools, and he has a bacterial pneumonia. Very easy. What's wrong?
The cystic fibrosis
Cystic fibrosis.
because of the kid and the recurrent pneumonia, bacterial pneumonia, and the steatorrhea is also there.
Decreased fetal elastase. Yeah.
Decreased fetal elastase.
Fecal elastase.
It causes the chronic pancreatitis.
Mm-hmm.
So again, very easy in terms of that. That the patient has large, small foul-smelling stools. Plus, he had bacterial pneumonia as well. Less than 10 years of age in cystic fibrosis is asorius, and greater than 10 years of age is what?
Pseudomonas
Pseudomonas
and Burkholderia.
Burkholderia.
Very
Yeah.
good. So greater than 10 years is Pseudomonas. Lesser than 10 years, the pneumonia is caused by asorius. They do ask you that in the exam as well. Again, cystic fibrosis has a lot of deficiencies, has a lot of problems going on. Sinopulmonary infections, pancreatic insufficiency, you have male infertility, bilateral absence of vas deferens. You do the diagnosis by elevated sweat chloride levels, nasal potential difference, genetic testing for CFTR. There's this thing, guanifacin, that we give in cystic fibrosis patients. Why? Because, it kind of thins the mucus and it drains out through the body then. There's one more drug that we give in cystic fibrosis. What's that? Come on, guys.
Can you please repeat the question?
How do we treat cystic fibrosis?
Enzyme, digestive enzyme, prion.
Mm-hmm.
What else?
Pancreatic enzymes.
There is some medicine
Lipases should be
like
given.
in the equation.
So there's this drug that's usually asked on Usmle step 1 in treatment for cystic fibrosis. It is ivacaftor. All right, it's IVACAFTOR CFTR modulators, ivacaftor, and that's usually asked on Usmle step 1 as well. So memorize that. All right, sometimes we give guanifacin as well because it kind of helps thin the mucus and drains it out of the body. All right. Next question. Okay, physical examination shows conjunctival pallor and loss of vibration and position sensation in the bilateral lower extremities and gait ataxia. The remainder of the examination is within the normal limits. Which of the following findings is most likely to be present on further questioning of the patient? All right. So we have a man who comes because of numbness and tingling. He has noticed that he tires more easily. Blood pressure is okay. Pulse is okay. Respiration is okay. What's happening?
Vitamin B12 deficiency.
Yeah, strict vegan diet.
That can develop because of strict vegetarian diets for past 6 years.
Yeah.
And it's not because of gastrectomy, because the gastrectomy is done 8 months ago.
Yeah.
And to develop vitamin B12, it takes
It takes
years.
2 or 3 years. Yeah.
That's why
Years.
So it is
a B.
Strict vegan diet.
Strict vegan diet.
Yeah, again, so we know that when we talk about vitamin B12 deficiency, it means that they're saying that the patient will be on a strict vegan diet for a very long time. Again, they will also have paresthesia, neural defects. Vitamin B12 deficiency also causes subacute combined degeneration, SCD. Okay, very easy. All right, then we go to the next question. Physical examination shows macular dermatitis of the extremities, water-soluble vitamin deficiency suspected as a cause of the condition. Which of the following biochemical conversions must use the deficient vitamin as a cofactor? So we have a patient who comes because of myalgia, anorexia, and skin rash. The patient works as a personal trainer and a bodybuilding enthusiast. Oh, raw egg vitamin. What deficiency?
Vitamin
Biotin B7.
B7.
Biotin, yeah.
Very good.
Mm-hmm.
It converts
Oh, yeah,
water.
Pyruvate to
That
oxaloacetate.
causes all the carboxylases will be affected. So the pyruvate to oxaloacetate will be affected here in this part.
Yeah. So we know that, in patients who eat a lot of raw egg white, they will develop avid biotin deficiency. Biotin is vitamin B7, and it's involved in a lot of enzymatic reactions, pyruvate carboxylase, acetyl-CoA carboxylase, propanol-CoA carboxylase, and like the carboxylase will be affected over here. Again, it will cause dermatological changes such as macular dermatitis. There will be altered mental status as well, but that's not usually high yield. High yield is the dermatitis that's happening over here. They also can have lactic acidosis. And yeah, all right, next question. Okay, what's wrong in the picture?
There's increased
Very high
hemoglobin and
hemoglobin.
total and indirect bilirubin. All are increased.
Hemoglobin.
All right. Patients when the jaundice resolved without intervention in 3 days. The patient jaundice was most likely which of the following changes in bilirubin metabolism. So we know that in children, what's happening, that there was this 4-day-old boy. The patient was born in term following an uncomplicated pregnancy. The patient and his mother are both Rh negative. All right. So which
R is
means that it's,
positive. Yeah.
sorry, Rh positive, yeah. So
Yeah.
they both are Rh positive, which means they don't have erythroblastosis fetalis, which means they're talking that in an infant that there is, a
Physiologic
decrease
jaundice. Yeah. This is the physiologic jaundice of the baby.
physiological. Why? Because of decrease in activity in
Like C.
glucuronide transferase. And because of that, the child has jaundice because there's a decreased activity of a certain enzyme. All right. Okay. What will happen?
So the bilirubin production will be increased and the conjugation would be decreased and the circulation would also be increased. It would be C.
Yes.
Yeah. So we know this, that in children that there is this physiological jaundice thing going on, and why? Because of this decreased activity of this enzyme uricoglucuronosal transferase, which I mentioned. So physiological jaundice, it gets resolved on their own. You don't have to do anything, and there will be increase in intrahepatic bilirubin circulation because there's increase in production, and cannot get conjugated because of the decreased activity. All right, then we have next question. You guys are doing amazing. This mutation prevents trypsin from being permanently inactivated by enzymatic cleavage. Patients with this mutation would most likely suffer from which of the following conditions? All right. So there's this mutation affecting the trypsinogen molecule that disrupts a crucial protein involved in inhibiting the active trypsin moiety. This mutation prevents trypsin from being permanently inactivated. What's going to happen?
It's pancreatitis because
Pancreatitis.
it's auto digestion of pancreas because of
Yeah.
constantly activated trypsin.
Yeah.
So it's going to be
D.
D pancreatitis.
Mutation is causing pancreatitis D.
Yeah.
so we know that. So see, remember I was talking about the SPINK1 mutation, right? So there's this SPINK1. It's usually, it causes hereditary pancreatitis. I was talking about this hereditary or autoimmune pancreatitis. It's because, mutation involving the SPINK1 gene. I told you guys this in the previous lecture as well. And that is something that can cause hereditary pancreatitis. And so this was a condition that involved the SPINK1. And yeah. Okay. Then we come to the next question, again, biochemistry-oriented question. What's happening is that they hypothesize that different monosaccharides delivered to the liver have different rates of intracellular metabolism. Which of the following substances is most likely to have the fastest rate of metabolism in the glycolytic pathway?
A. Fructose and phosphate.
Fructose 1-phosphate.
All right. Again, very biochemistry oriented. So we will cover this. It's Unfortunately, you have to memorize this. There is no, sega way to learn the concept behind it, but it's just a very memory oriented question. I hate how USMLE step one is just, root based memorization. But unfortunately, that's the case. You have to memorize this. There is no set concept behind it. All right. Okay, then we come to the next question. Tenderness and swelling are present with the right distal radius. Parotid glands are enlarged, all right, and there are fine soft hair on the extremities. Uterine pregnancy test is negative. X-ray reveals a non-discrete fracture of the right distal radius and generalized radiolucency at the bone. Okay, then that means that there is some, BMI is 18. She's anorexic. Um, or okay, what's happening?
It's the anorexia nervosa because her BMI is at the range of anorexia because she is not probably binge eating. And those other soft hairs are the lanugo, which are appearing on her body. So these are all the features of anorexia nervosa.
Yeah. So we know that if there is BMI less than 18.5, then that means we're talking about anorexia nervosa. Anorexia nervosa patients have nutritional deficiency, and as a result, have parotid hypertrophy as well. If binge and purge behavior is present, they are prone to osteoporosis, amenorrhea. This is called functional amenorrhea. Why it's happening? Because they're nutritionally deficient, and they're also more vulnerable to arrhythmias as well. Um, Again, very easy. Again, anorexia nervosa is usually found in people who struggle with body image or body dysmorphia, and that is why those patients have that. In bulimia nervosa, the BMI is normal. And what else? What else happens in bulimia
Binge
nervosa?
eating.
Binge eating. Very good.
Mhm.
All right. Okay. And then we have the second last question for today. Pseudo staining of a fecal specimen is positive, and the fecal occult blood testing is negative. Blood testing reveals normal hemoglobin. Which of the following pathophysiological changes are most likely present in the patient? All right, so we have a 54-year-old man. He comes to the office for evaluation of chronic diarrhea and weight loss. He has had bulky foul-smelling stool for the past 8 months, which usually occurs shortly after eating. There have been no nocturnal bowel movements. All right, there is dull epigastric abdominal pain that's exacerbated by eating, and it's unrelieved by acids. The abdomen is tender to palpation. The epigastrium without distension, rebound, or guarding. What's happening?
It's
Pancreas insufficiency.
gastric also, and it's the bleeding regularly.
This
Increased level of elastase.
Yeah,
is
decreased
the
level of
period
fecal
Level of
elastase.
elastase.
so it's going to be
Which
decreased
causes
level
the
of fecal
bulky fold
elastase.
smelling stools.
Okay, so the answer is
B.
again, so very easy. We're talking about chronic pancreatitis, which means the patient is having epigastric pain that's worse with meals, and he also had an alcoholic history, which means we're talking about chronic pancreatitis. Those patients will have decreased level of fecal elastase. Remember that lipase is usually normal in these patients. Okay, so lipase is usually increased in acute pancreatitis.
Acute pancreatitis, yeah.
It's not a marker for chronic pancreatitis. So lipase will usually be in the normal limit. All right. Okay. Next question and the last question for today is BMI is very less. All right. She has a well demarcated, hyperpigmented, scaly rash on the hands, forearm, and upper chest. It is determined that the patient is deficient in a vitamin that is used to synthesize the NAD enzyme.
Niacin deficiency.
In niacin deficiency, dermatitis.
Tryptophan.
So we see that there is dermatitis, there is dementia. Okay, with tryptophan, we all
Yes.
agree. All right.
Liver.
So we know that niacin is involved in a lot of things, and pellagra, like we mentioned, that it's because of niacin deficiency that presents as dermatitis, diarrhea, and dementia. It can also cause death. So now it has been updated for these. Again, very easy question. So which means that the precursor tryptophan is kind of like used over here. And other thing is heart-numb disease. What do you mean by heart-numb disease? What is heart-numb disease, guys? Anybody? No?
No.
It is a disease in which there is the hereditary abnormality of the absorption of certain amino acids.
Amino acids, yes, I
Yeah,
think.
in the children.
No, it can yeah, mostly. Why is it named heart-numb? So it was named after the British family Hartnett who had this disease, and that's why it was kind of named after them. Again, we know that there is a gene mutation that's occurring. It is an autosomal recessive metabolic disorder that is affecting the absorption of non-polar amino acids, and that is why we get Hartnett disease. How does it
And also,
present?
also with the deficiency, genetic deficiency of tryptophan. I think so. Huh?
Yeah. How does it present?
I think it presents with dermatitis, diarrhea, and
Yeah, it presents with the same symptoms as pellagra.
yes.
Alright, diarrhea, dermatitis, dementia. Again, it's a disorder that causes a decrease of the amino acid tryptophan and certain other non-polar amino acids. We know that tryptophan, it is an essential amino acid, which means that it cannot be made in the body, but it should be consumed through the food. Also, in heart-numb disease, you will get excessive amino acids that will be excreted in the urine. So when you do a urine test, you will find that the patient is having excessive excretion of amino acids. And with that, we are done for today, guys. Do you have any questions?
Yeah, Dr. Maheen, necklace like rash also is the
I'm sorry, I
presenting
cannot
feature.
hear you, Amna.
Oh, can you hear me now?
Yeah, yeah, yeah.
Yes, so the niacin deficiency also presents like necklace-like rash.
Necklace-like rash?
Yeah, they have it
Color
like
rash, color rash.
collar rash, like it's called necklace
Yeah.
usually.
So it can present like any type of rash because the dermatitis can happen throughout the body. So there is no distinct type of rash that can be linked to niacin deficiency, but it's mostly dermatitis that's happening, so it can present with any type of rash.
Okay, okay, thank you.
All right. Okay, guys, we're done for today. Do you have any questions? No? No? Okay, then Dr. Ahmad will take over. Dr. Ahmad, are you here?
Yes, I'm here. Thank you so much for your amazing session, and thank you so much. Okay, so I
Okay.
have. Thank you. You guys have any questions from Dr. Maheen? Okay.
Excuse me,
Uh,
Dr. Maheen, could you please share the high-yield histology images of the GI?
I think Dr. Maheen have left the session. No problem. I'll just
Thank
tell
you.
her she's going to share. Okay. So
Thank
today
you.
I'm going to introduce you with another amazing person or your tutor, I would say, Dr. Aliza Azad. Okay. So Doctor, are you here? Dr. Aliza?
Yes, yes, I'm here. Yes.
Okay. Perfect.
Hello,
Perfect.
everyone.
Okay, so we have assigned Dr. Aliza to be your tutor for these remaining your system that is going to be your GI and Repro. And I and Dr. Moaz mainly are going to focus on the revision session. So basically, we are working on that. We want like integration of Malman PDFs in that. So we have to work a little bit, right? So let her introduce herself. Yes, Dr. Aliza, can you just please introduce yourself to your students?
Yes. Hello, everyone. I'm Dr. Lisa, and I have given all my steps recently. I have scored very well on my step 2 exam. It's 260 plus, and same goes for my step 3. It's 240 plus. I'll try my best to help you all, and I wish that you understand whatever I teach you.
Yeah, so she's very experienced tutor. So Dr. Lisa, can you just please tell our students regarding your tutoring experience?
Yes, yes, I would like to. I have actually been tutoring students for more than half an a year, and like 1.5 in a year, and all my students have passed their exam. So it's my success that they pass their exam, and I wish that all of you that are here pass your exam too.
Perfect. So Dr. Eliza have joined our team NextGen Usmle. She's going to be here like for a long period of time. So you're going to see her again and again. Okay, and as well as we are also trying our best to bring such an amazing mentors for your research purposes as well. So today's session is going to be taken by Dr. Eliza. So Dr. Eliza, can you just please start today's session?
Yes, yes, I can. Okay, so today we will talk about liver pathologies. Okay, so let me share my screen. Can you all see my screen? Okay. So today we are
Yes.
going to talk about liver. Yeah. Today we are going to talk about liver pathologies. Okay. So first thing we will describe is jaundice. Like you can see three types of jaundice. I would say. Okay. It depends upon what area